but my topic is rural obstetrics because it's something that's changing and something that really interests me, and it's part of the career path that I've chosen. So as he said, I am family medicine, but I do deliveries, and I also perform C-sections. And we'll talk a little bit more about how I came to that path and what the future of obstetric care in rural communities looks like in America and some of the challenges we face. So the first thing that I would like to talk about is just what my inspiration was to become a rural doctor and sort of my path that got me there. And then we're just going to, it's a little bit of a side tangent, but I think it relates overall. It's a cautionary tale from history about obstetrics and doctors, and maybe a little bit of hubris in there. And then we're going to talk about the history of obstetrics in the United States, kind of where we are currently as far as the migration to, delivering in bigger cities and smaller hospitals, either shutting down or getting rid of their obstetric units. We're going to talk about how things are going to change and maybe what the future of obstetrics looks like worldwide. So I grew up in North Logan, Utah. This picture isn't actually very far from where I grew up, so it was a great place to grow up. I used to walk over to feed our horses in the morning before I would walk to school. My parents didn't drive me to school once, and I had a cello. I played the cello, so every once in a while I'd have to haul that thing around. I'm sure it looked pretty funny, but I kind of felt like I was on my own, and I really liked that. I could ride the horses up in the canyons up there, and I just really liked growing up in a place with lots of open spaces and room to explore. And I felt like when I finished with all my training, because most medical schools are in bigger cities. I went to medical school in Salt Lake City, so I was sort of forced into captivity in the bigger cities. So I knew always that I was going to get out of school and move to a more rural community, and found the job here in Vermillion and loved it. But another picture from what it was like growing up where I was from. The biggest thing that I was jealous of when I moved out here and did a lot of driving back and forth across the country was seeing how green everything was and how much things were able to grow out here without water. Because if you don't water something out where I'm from, it turns brown and it dies. So that made a big impression on me as I was moving out here. And when I was young, I read, like many people, East of Eden, which is a book you can read over and over again. But one of the things that really made a big impression on me was the doctor in the book. Now, one of the things that I liked about the doctor in the book is he doesn't have much of a story. He's kind of, he's a caricature of a physician, and he is involved in everybody's life, but also not a very big part of the story. He's not a big personality, and I kind of like that. Being more of an introverted person, I like to maybe be on the periphery and observe and know a lot of things that are going on, but not necessarily be the center of attention and right in the middle of the whole framework of the story. He of course would kind of go to people's houses when they needed them, and that was something that really impressed me. He was always kind of showing up, always traveling around. And he would also, he just carried his little bag, and if he needed anything else, if he needed sheets or if he needed this or that, or if he needed to sanitize some equipment, he would use the tools and the things that were in the people's houses, kind of make them, turn them into the nursing staff. And that really kind of appealed to me. I thought that was interesting. And of course, in that time, people were a little bit more self-sufficient. They had to be, right? I went back and I read this scene because at first I had thought that it was the physician who was there at the childbirth. I don't know if you guys know the story of East of Eden, but when the two twins are born, it's kind of a big ordeal and it's scary, and of course it's a younger set of parents, and Kathy has her own issues, but she's going to deliver these babies, and her husband, Adam, does not have any idea what's going on. So someone has to kind of show up and slap him around a little bit, and the first thing the doctor does, and it's not actually a doctor, it's Sam Hamilton, but I thought it was the doctor when I was thinking about this. But he shows up and he pretends to be a doctor, which is just as good, and he smacks him around and he says, "You got to go boil water." And then somebody asks him, or he thinks in his head, he said, "Well, why does he have to boil water?" He's like, "We don't need boiled water, but I just needed to give him something to do so he'd get out of the way." So really a great scene, and one of the things that happened there, which would actually happen later in my life, is there were twins, of course. And they didn't know that they were twins until after the first one was delivered, and they said, oh my gosh, there's another one. So I'll talk a little bit about another story where that happened to me as well. And so it was really just a matter of kind of showing up and saying, okay, this is going to happen, and you know, we're going to do the best we can to get through this, and having a plan. There's a saying in general surgery, which I think applies to life in a lot of ways, and it's sometime in error, never in doubt. And I think that is important, because even if you don't know exactly what the best thing to do is, by gosh, you got to have a plan and you got to stick to it. And it doesn't mean you can't change it if you don't need to, but it's better to have a plan than no plan. So there was a great painting on the wall of my hospital, and I spent a long time looking for it. This is not it. It was a great painting of this rural doctor, and he's holding the baby, or mom's holding the baby, and he's nearby and maybe has his bag, and it's clear that the birth has happened and everything is well and the sun is shining and it's great. But this is another great rural physician painting that I love, and I think this one is related to typhoid, but essentially the feeling is the same, that the doctor shows up and he's obviously very concerned about this child and a little bit perplexed. What am I gonna do here? He's obviously maybe not winning this battle, and the mother is pretty desperate in the background. There's a look of trust on the father's face, and this doctor has showed up and he's gonna give it his all, but you can tell he's pretty concerned about the situation. So a little bit more about me. When I left Logan, I traveled all over the world. I had a lot of wonderful experiences. This is the Taj Mahal in India. So I had a passion for international travel. I also worked with a school in India where I would help to teach children English and things like that. It was a really enlightening experience. It was, difficult at times, but obviously very enjoyable, and it was kind of one of my first experiences with international work and care, and kind of seeing that it's not all, you can't just go in and fix something, that the challenges are abundant. And I don't know if any of you guys have read Paul Farmer's book, Mountains Beyond Mountains, but that is, to me, like, when you talk about any sort of international volunteer work, whether it's hospital-related, healthcare-related, education-related, you see the mountains in front of you that you're going to try to take on, and don't worry, when you get to the top of those, there's going to be mountains behind them. But didn't hold me back. Does anyone know what mountain that is on the left? It's kind of famous. Everest? That's Everest on the left. This is Nipsey on the right here. But Everest is much taller, just a little more in the background, so it kind of looks a little bit shorter. But this is Everest Base Camp down here on the right, and then you go up the Khumbu Icefall there and up the step. I'm told, I have not done that, and I don't plan on it. But it was fun to take a look. Still took about 30 miles of trekking to get to this point from the nearest airport. So a lot of fun, kind of that same time period. So I came home, I graduated college. I didn't take any pictures of that because all that was pretty boring, but business and Spanish literature was a lot of fun. And then I became a ski patrolman. I also became an EMT and a paramedic. I worked up in the ski resort, and we had all sorts of patients, from really sick people who ended up passing away to these guys who were more looking for a ride than any sort of medical care. But it was a lot of fun. This picture on the right is pretty amazing. I went on exchange up in Canada, and there's kind of a tradition. So this is at Whistler Blackcomb, which is one ski resort now, and this is on the Blackcomb side. And there's a tradition that when guys from a different ski resort come, you give them the hardest time you possibly can. So they took us over to this thing, and I don't know if you can see that ribbon of snow that I'm skiing on, but the worst part about it is that it tapers off to the right. So if you fell, you would just go right over those cliffs, which luckily I didn't. But there was also some guy on the patrol who was out totally miles away across the valley who had a new telephoto lens for his camera, and he looked over and shot a couple of shots. And so that's how we have that picture, but I'm sure right in that moment I'm thinking, what did I get myself into? I'm not coming back to Canada. So when I was a ski patroller, I met a really awesome surgeon from Utah, and he had worked in Nebraska, and one of his partners in Nebraska used to go to Haiti to a medical mission, and they would operate down in Haiti, and that was really inspirational to me. And of course he invited me along, and I jumped at the opportunity, and at this time I wasn't quite sure what I wanted to do. I was liking my life skiing and being a ski patrolman, a rescue guy, and didn't really have big plans to change that, but got to be hands-on. This is the surgeon here on the left. Of course, he was doing everything, and I was just doing what I was told, but it was still a lot of fun and really inspirational. And the thing that I really liked about surgery is, you know, compared to some of my other experiences with international aid work, with surgery, you can go into one person and you can change their life. And their philosophy, you know, it's kind of a famous tale, but their philosophy was have you ever heard the story of the starfish, where some people are walking on the beach and they just see thousands of starfish who, for some reason, there's been like an exceptional high tide and they've all washed ashore and it's a bright sun out, and you know they're all going to die essentially. And one person says, "What's the point?" And the other person picks up a starfish and says, "Well, I can save this one." He throws it back. Then he picks up another one. "I can save this one." And he throws it back. And you know, going to Haiti was always a really emotional experience, and watching now all the trouble they're having in Haiti, it's really emotional because we know a lot of people down there, and it's different when you've never been to a place and you don't know anyone, and I'm sorry, but you see some pretty amazing things and some pretty amazing people. And I remember on Sundays we would go to church, and just the happiest people would be singing, and the little girls with their pigtails and their dresses, it was really exceptional and impressive to see. And just in probably it is the poorest country on the planet, just to see the amount of happiness that they have and the joy that they have and the love that they have for each other, it was a pleasure to help them. And it's easy to look at the whole country and say, okay, well, we can't save these starfish, but we helped a lot of them, and I was really proud to be a part of that mission. So as you can see, I was also happy while I was down there. I didn't just cry the whole time. But it was a lot of fun, and it was really good. It was a great opportunity for people who were in medical training to go and to be a part of these teams, because really anyone that we could get down there, everyone had to chip in and had to be a part of the team. So I was doing everything from working as a scrub tech to sanitizing the tools and organizing the different surgical instruments and things like that. So, you know, it was kind of a morning to night, hard work but fun. And I will never forget, there was an older gentleman. He was probably in his 70s, and there's this terrible thing they get in Haiti. It's called a hydrocele, and it's just way worse than any that we would ever see up in America. And there's some theory that it has to do with parasites down there, but essentially his hydrocele had grown to a point where he had a tumor between his legs that was maybe close to the size of a basketball. I mean, it was just remarkable. Rail thin guy, and he was walking to the operating room and shaking everyone's hand as he walked by, and it made a big impression on me. And he just said, "I've been in pain for so long, so thank you for coming to help me." Because there was really no chance that he would ever, you know, have any surgery or have any relief from that without us going down there and volunteering our time and skills. So the story that relates to the surprise twins was, one time there was next to the mission where we had the operating room where we could do our work, there was a birthing center, and most of the births were done by midwives, but there was one where there was this really young lady. She was super frail. She was 19 years old. And she was really pregnant, and she'd been pushing for a long time. And the midwives came and they said, "This is not going well. This is not going to happen. Perhaps you guys could do a C-section." When the surgeon, of course, had not, but he was, you know, understood that when these Haitian midwives who had delivered thousands of babies said that there was a problem, that meant there was a problem. So we got her on the table and we performed the C-section, and he was very careful, and he did a vertical incision the way he was accustomed to instead of the classic, which is more aesthetic than anything. incision, and we got one baby out, and lo and behold, there was another baby in there, which was probably part of why it was so difficult for her. But both twins survived, and it was a really great result for them, whereas all three probably would have died had we planned our trip a week earlier or a week later. And then I started medical school, and the biggest experience that I had in medical school was down in Beaver, Utah. It's a tiny little town, and it's got a hospital, much like Vermillion Hospital, that just has a couple of doctors, and they all take turns, and they deliver babies, they do C-sections, they cover the emergency room, and they all run clinic as well, which was really inspirational to me. Because it was like, wow, these guys do a lot. So coming from a rescue background, that was kind of one of the first times that I was like, you know, maybe I would want to deliver babies, because it hadn't really occurred to me before then that that was something that I would like to do. Another picture of Beaver, Utah here. And one of the most important things about here is not necessarily the size of the community, but the distance, right? So this is 2 hours to St. George and 3 hours to Salt Lake City. So if you're, and that's if you're driving fast, which you can do out there. So, you know, if you're having a baby or you have a pretty serious problem, you can't make it your way either way. You have to be prepared to do a C-section right there, and of course they were. And that was inspirational to me. So, hospital pretty much the same size as Vermillion Medical Center. So now I'm going to just take a brief detour and just talk about obstetrics and doctors. I don't know if any of you recognize this gentleman. I would be absolutely amazed if you did. This is Ignaz Semmelweis. He's a Hungarian physician. I always thought he was Austrian, but he was actually born in Hungary, but he spent most of his professional career and training was in Austria. And at one point, he was working in Vienna General Hospital. And he looked around and started to notice something that was pretty obvious when you look at the numbers, but nobody else wanted to think anything of it, and that was that if the women had their baby delivered by a physician, they were much more likely to have an infection postpartum and, of course, you know, subsequently die in the absence of antibiotics than if they were to be delivered in the midwife section. And he couldn't quite figure out exactly why. And the biggest thing was that the physicians did delivered a lot of babies, and they would go from mother to mother to mother. And of course, they wouldn't wash their hands and they wouldn't wear gloves, because the thinking back then was doctors are gentlemen and gentlemen's hands are clean. The other thing that the physicians were doing that the midwives weren't doing is that they were doing autopsies. Now, this wasn't at a time when they would pump the body full of formaldehyde. These were real bodies, and these were decomposing. So the physicians, now logically, we understand that they were taking bacteria from the autopsies, from the other actions they were performing, and not only were they giving them to one mother, but they were passing them between the mothers as well, because they wouldn't wash their hands. And so he noticed that puerperal fever was much more common with the physicians than with the midwives, and he came up with his theory. Now, of course, everybody just got right on board and they started washing their hands and they congratulated him. No, this is Austria, and this was back in the 1800s, and he was ridiculed and he wasn't treated very well. And in fact, he ended up losing his job, but he really fought hard for this. So these are kind of the rates of infections, and if you look in the first clinic and the second clinic being the one that was run by the midwives, there were much fewer deaths. And there's the same data on a graph that you can see that in the red line is the physicians and the green line is the midwives. And then at one point, he was able to convince them to wash their hands. Now, this was before Lister's theory and all of the kind of embracing of microbiology, but he was able to get an intervention through where the physicians would wash their hands, and then their rates of infection actually began to approximate those of the midwives. And he ended up on a postage stamp, so that's a really good thing. So it just goes to show to always be humble, and you don't always know how you're affecting things. And if you can see that there's something wrong, you don't necessarily need to know exactly what's causing it. They didn't have germ theory. They didn't understand the microbiology at that time, but they understood that if they washed their hands, then these infections would go down. So now we're going to talk a little bit about the history of obstetrics in the United States. And I think this is pretty impressive, and I think a lot of us know this logically, but to actually know the numbers, that at the beginning of the 1900s, pretty much 100% of children were born at home in the United States. And that's not too long ago, 120 years ago. So 100% of births were at home. And then by 1938, it was 50%, and now we're at 99%. Now they do talk about home births increasing by 41%, but that's 41% of 1%. So we're still up at that 99% of babies now are born in hospitals in the United States. This is and I divided this up. It's a really nice timeline of the history of childbirth in the United States. And the things that I think are important here is if you look at 1952, 80% of babies in Oklahoma were delivered in hospitals. So if you start at that 1900 where most babies were delivered at home, not just most babies, but 99% of babies were delivered at home, then by 1952 even Oklahoma had been getting on board there. And then in the 1970s we start to see nurse midwives appearing, and I think that's wonderful. I think anyone who has the training and the dedication to want to deliver babies is great, but a nurse midwife can't deliver babies if they're not prepared to go to C-section or go to surgery if something bad happens. No matter how good of a midwife you are, you can't stop a cord from prolapsing, you can't stop a uterus from detaching prematurely, or a placenta from detaching prematurely from the uterus and having massive bleeding. And so these are rare things, but you always have to be prepared to go to C-section. In fact, I had a vaginal delivery the other day where we ended up going to C-section, and the cord was wrapped around the baby's neck 4 times, and we couldn't see that. We didn't know that that was happening, but luckily we had that ability where we could go to C-section, and everything turned out really well. So here's kind of getting to the end there. By 2015, 99% of babies are delivered in hospital. Obstetricians delivered 86%, and nurse midwives attended 8% of births. So I'm not an obstetrician, I'm not an OB-GYN, but I was trained by OB-GYNs in vaginal delivery and C-sections in my training. Now some family medicine programs, they don't focus on the vaginal delivery. You have to have a certain number, but they don't focus on deliveries, they don't focus on C-sections, and others do. And I went to a program that was recommended by those Beaver doctors up in northern Utah that really heavily focused on obstetrics, because I realized, you know, I really like procedures and I really like to be involved with some of these bigger cases, but I realized that the old family doctor who used to take out appendixes, who took out tonsils, who would put in ear tubes, that those things, you know, aren't emergencies. I mean, appendix is an emergency, but you can get someone where they need to go, but to get it taken out in an hour or two. But if a mother has a problem, you don't have an hour or two, you've got minutes. And so I quickly saw the writing on the wall that one of the most valuable procedures that you can perform in a rural hospital is a C-section. So I really dedicated a lot of time to getting that done. Okay. So right now, as I talked about before, compared to 1900, now we're at 98.4%. And then there are these freestanding birth centers as well, which are often attended by midwives, but most of these are located within a reasonable distance of a hospital where they can take the mother if they need to for a C-section. But rural hospitals are really struggling. And so this is the total number of hospitals in the rural areas. It's 35% of the nation's 5,000 community hospitals. And they deliver 1 in 10 babies in their areas. And these are all considered rural hospitals in rural counties. Most of them would be considered critical access hospitals as well. So if you look at that, that's 333,000 births in 2020. So now, over the years, many of these hospitals have stopped delivering babies altogether, or shut down their obstetric services altogether. And now I think it's about half that are still doing that. And then between 2015 and 2019, there were 89 obstetric units that were closed across the country. And so then there's more than 2.2 million women of childbearing age in America who live in maternity care deserts. So they don't have a hospital offering obstetric care, no birth center, and they do not have an obstetric provider. Now there's some small hospitals now where they'll do the obstetric care in combination with a hospital in the city, and sometimes they'll alternate visits, so the mom will go to one visit at the rural hospital and then she'll go to the city and she'll come back, or they'll do all the visits before a certain number of weeks and then mom will have to travel for those. So that's a way of getting prenatal care without traveling quite as much, but usually that's within the same corporation, some sort of a partnership with the city hospital. So now we're going to talk a little bit about how these things are changing. So we all know that in America the fertility rate's going down, birth rate's going down, but the birth rate is still much higher in rural counties than it is in these larger metro counties. And so even though the overall trend is the same as far as birth rate and fertility rate, rural counties still have a higher fertility rate per capita than the metro counties. And I think it's safe to say that these current trends are going to continue, that we're going to see less and less hospitals provide obstetric care. You know, we do know that there are higher fertility rate in rural counties, and I would imagine that if there's, you know, there are a lot of young families that come to Vermillion, and I also represent maybe someone from the younger generation who decided to come to a rural community to live, and there is a trend towards younger families moving to rural communities across the country too. So I would imagine that'll only continue to go up. But if you live in one of those obstetric deserts, women are just going to have to drive further and further, and if something happens, then they are going to be pretty far away from a hospital, or they may be showing up to a hospital that doesn't have an obstetric provider on call, so they'll be stuck with an ER physician or whoever there is there. And we know that if women don't live within an appropriate distance of a hospital, if they live in one of these maternity deserts, is associated with poorer outcomes. It's associated with an increased chance of preterm delivery. So, you know, this is our mountain. This is what we have in front of us, and what are we going to do? How do we potentially address this? See, we have this lifeline threatened, and it's not just about dollars and cents. It's about, you know, building American communities and having American children that are going to be our future generations. And also, if you lived in an obstetric desert, you'd probably be less likely to even want to have a child, because you'd be concerned with, you know, I don't know who I would go see, I don't know where I would deliver, I don't like making the drive to so-and-so place, so that may even kind of decrease women's chance of wanting to have children. So the biggest problem is it's really hard to recruit physicians who are willing and able to provide obstetric care. And as I said before, you know, this is associated with an increase in preterm births and worse outcomes. So the American Hospital Association has 3 possible ideas about how they could fix these problems, but they're not easy, and even if they're perfectly implemented, I don't see them necessarily turning these trends around. But one of those is to expand access to prenatal care and clinicians, you know, really getting women that chance, you know, even if you're not able to see the obstetrician face-to-face, having that meeting, whether you have to partner with a hospital or you have to do telehealth services, whatever you need to do to really make those services available to try to decrease that preterm delivery rate. Also exploring partnerships. You know, where I came from in Salt Lake City, I worked at Primary Children's Hospital as well, and they have a telehealth program that does tele-NICU, so they're able to not just talk on the phone with a physician, but maybe take a look at the baby on the video camera and do a little semi-video chat and allow these hospitals to maybe keep the baby if the NICU doctor says that's okay, or of course send them if they're really concerned about how the baby's doing. And the nice thing about that is that makes these smaller hospitals more likely to want to potentially, you know, continue to perform these services, you know, that they have the support. I know that we're really well supported by Sioux Falls here in Vermillion. I can call them anytime. I can get an OB on the line, I can get a surgeon on the line, I can get the NICU doctor on the line, and they can kind of listen to our story and give us ideas. So that helps us to feel supported, that we're not just out here on our own, because that can be a scary feeling, of course. So these are some the South Dakota birth rates, and so this is for 6 years total, 2017 to 2022. And you can see that this accounts for 69,000 in that bottom right corner births in South Dakota. Now, one thing that's amazing about that is that, I think it's of the 69,000 births, 30,000 were born in both Avera and Sanford and Sioux Falls. So that right there you have about half of the children who were born in South Dakota in the last 6 years were born in Sioux Falls, either with Avera or Sanford. Then 11,000 were born in Rapid City, and then 4,000 were born in Aberdeen. Now, so you've taken out a big chunk, probably close to 75% there between those three places, but that's a lot of other children that need to be born in rural counties and other places in South Dakota. So where is that going to happen? And Vermillion's part of that answer. And there's the fertility rates a little bit above the national average out here. And this is Vermillion. Now, I had to cut out the middle section there, but these are actually all the different places in our surrounding areas where our obstetric patients come from. But the important thing here is if you look at, so you look at that 60,570 were born here in Vermillion in the last 6 years. And these are just all the different counties and places they came around. So not a small number, I mean, of 60, that's, close to 1%. Or more than 1%. And here are some names of all the children that were born in Vermillion during 2013, so before those statistics were started. And then the last couple of slides here, just talking about the future of obstetrics worldwide, because in the United States we're certainly seeing a drop in fertility and a drop in birth rate, but worldwide we're seeing vast shifts. We have countries like South Korea and Japan, which we know that they're shrinking and their birth rates are completely plummeting. But here, if you look at the fertility rates in 2014, you get a huge concentration here in sub-Saharan Africa, where the average woman is having 4, 5, 6, 7 children even, whereas the rest of the developed world and a lot of the developing world has really tapered off as well. So, but still worldwide, only 86% of pregnant women have access to antenatal care, and 2 in 3, so 60%, will actually receive as many as 4 prenatal visits. So, and then just talking about those countries there that are going to continue to grow over time. It's actually interesting. So now, with China, you have that it's projected to reach a peak population here soon as well. So it's not even really considered in fact, it shrunk last year for the first time, whereas some of these African countries are going to continue to grow and grow, and some of them will have, their population will have increased by 4, 5, 6 times in the next 100 years if things continue the way they are. So that is the end. And here is me. This is on Denali up in Alaska, if you guys have heard of it, at 16,000 feet. And then that's another picture of me out in Haiti. I'd be happy to answer any questions. Yes?
You mentioned telehealth. How helpful will that be, especially in this area, in the area of obstetrics delivery in rural hospitals? I mean, we saw hospitals up there like Winter or Wagner.
Yeah.
Will telehealth be able to fill a gap to the extent needed, or is it temporary fix? Is it just as good as we can get?
I think telehealth is most helpful in 2 areas. One, in the prenatal term, where you may not have an OB-GYN or a physician there, but if you can get the mother to that hospital, which is a much closer to her house than the hour or 2 that she needs to drive to go to a bigger city, then maybe you could get her on the phone or do a video call with an obstetrician in the city, and then she would know who she was going to end up going to see, so she may be more likely to follow his instructions. Hey, if you have any bleeding, if you're having so many contractions an hour, get on the road and start driving over here, and she may be more likely to follow up there. The other place that it's really helpful is in the aftercare. Now, if you're a hospital and you're deciding, do we want to still deliver babies or do we not? You know, one of the big things is not feeling like you have the support of, you know, if baby turns baby turns downwards and is not doing very well, you know, who are you going to call, and are you going to be able to get them transferred or even flown if they need to quickly? So I think those two areas, but of course, you know, we're never going to be delivering the babies via telehealth. So that's something that needs to happen in-house, and you need to have, I mean, it's 24 hours, right? You need to have somebody 24 hours, 365 days a year who's ready to come and perform a C-section if it's needed. So, yeah. Any other questions? All right, thank you very much.
Well, when it comes to taking care of our wives and daughters and babies at their most vulnerable, I'm glad we have people as caring as Dr. Cannon. So thank you. Thank you, Ellen. It's nice to meet you. Cindy and Rachel, thanks for coming. Anna, hope to see you again regularly. Next week, we have Dr. Renelle Nissen from the OT USD Occupational Therapy Department.